Hello, everyone. Welcome to another episode of Fertility Focus. Today, we're taking fertility preservation. It's not a gender-specific topic, but for the essence of what we're trying to achieve today, focus more on fertility preservation in females of reproductive age. And I've modified this presentation into three sections, the first one would be what kind of patient qualified to be in this group of patients that that might benefit from fertility preservation. And secondly, we'll talk about the universal pathways involved in onboarding and helping this patient go from exactly why they come to you to help you preserve their fertility for a future day. And the third one would be the available interventions now globally and what we have applicable here in this part of the world. And once we are done with the third section, we'll go straight to some frequently asked questions, just to make sure that we hit every point and help everyone come on the same page, to help us understand why this is so important in this time and age where fertility rate is on a rapid decline due to a lot of reasons. We have a lot of career women now that we believe that they should be able to chase their career and also bear children at the right time without having to go through the stress and the emotional turmoil involved when it comes to trying to conceive at a more advanced age, usually older than 35. So that being said, I'll define the concept of fertility preservation simply, as is said, is the ability to help a woman preserve her fertility for use at a later date. And then there are two concepts about this. So there's the medical and then there's the non-medical indication for this. So the non-medical is what we usually call social freezing, right? But it's not usually an acceptable word to use, so we just use non-medical for it. It's more acceptable that way. And without further ado, we'll go straight to our breakdown, which would be number one: what patient group do we know should benefit from this process? And after that, we'll go on to the universal pathways involved, and then lastly, we'll talk about intervention before we go into some frequently asked questions that we're going to dissect, just to help you understand the importance of this topic in this day and age and time, where women choose to suspend childbearing for a lot of reasons, betterment of their career, in sports, also, this is a call for our celebrities. We understand the concept of being in the face of the media all the while, and not having that window to bear children, exactly where you want to. And the idea about this is that you don't have to pay heavily for it, chasing your career and then having to put childbearing on the line for you to do that. And then at the end of the day, when you're ready to set up a family, those leverages, when I mean leverage, which age is going to be the most important factor here, is no longer on your side. So going straight to our point, our breakdown point would be patient group. What patient group are we looking at, when it comes to fertility preservation globally? So the first group would be fertility preservation in pubertal women. When I mean pubertal, this is not applicable, or let me say there are no research shown that any of these interventions before puberty, really, increases our chance or conserve our chance of bearing child at the appropriate time, for these women in question. So, like I said, for the patient group, we have the first group would be fertility preservation in women recently diagnosed with cancer. The second group would be fertility preservation in postpubertal women with genetic disorders like Turner syndrome, where a woman is delivered with a single X chromosome instead of double, which reduces their chance at maturity, their chance that menarche, which is onset of menses. It also increases their chance of premature ovarian failure due to reduced ovarian function. and this is happening before the baby is even born. We see those kind of cases too. And then the third option in the patient group will be trans men, which is very, very sensitive. And I don't think this is a platform to talk about that. However, our doors are open for this category of patients to talk about options, getting them from where they are to preserving their fertility and then helping them conceive at a future date effortlessly. And the fourth and most important here would be the category of patient we call age-related fertility loss. And before we go further, I have to emphasize that in females, the most important factor, or let me say the most important determinant of fertility would be age. However, in some cases, you see, so the age concept would be that once a woman clocks 35, there's a rapid decline in ovarian reserve and number of accessible follicles, which also results in reduced quality of this oocyte. So technically, it's not just about getting eggs; it's about getting good quality eggs that will get you from the point of collection to the point of preservation. That will also see you through fertilization, see you through confirmation of pregnancy to a safe delivery. And like I said, I think this fourth patient group is the essence of this presentation, and it is age related. Um, why is it age related? I'll just take my time to explain that. It is because, scientifically speaking, every lady, every woman born comes to the world with a finite pool of eggs. What I mean, a finite pool, it means that we already know that as the baby girl is already in the uterus, she has about, we call them primordial follicles, sometimes usually up to 6 to 7 million. And by the time they are delivered, it further reduces. By the time they attain puberty at about 10 to 15, it reduces to about, say, 25,000. And by the time they go from that puberty to menopause, there's a gradual decline that gets worse when you get to age 35. And by the time you're attaining menopause, you know that those 6 to 7 million eggs, that were yours, from the uterus, at that point at 45, we have access to just 1,000, which makes it usually more difficult to achieve pregnancy at advanced age, usually greater than 35 years old. That being said, we'll go straight to the second subject here, which will be the universal pathways to fertility preservation globally. And there are 5 components under that, and I'll go straight into it. The first one would be information and decision making. You need to be able to advise a patient accordingly based on what have brought them to you, and what are the chances at the time of seeing them of going through this process and having the desired outcome at the time when they actually need to conceive. The second point here would be the pre-fertility preservation assessment, which is very, very important. And why do I say it's very, very important? Because even in normal treatment, assisted reproductive treatment, it is very, very important to know where your patient falls. So we have the high responders, we have the normal responders, and then we have the low responders. And without categorizing your patient, you might just be doing a lot of wrong things that might not benefit the patient in any way, getting them from where they are to where they want to be, which is to have babies of their own. And then the third universal part here would be fertility preservation interventions. And we all know that that's the reproductive technology, but there are different modalities to it. The fourth point there would be, what kind of treatment is this patient going to be having? How toxic are these chemotherapy agents you are going to be using? How much effect do we expect the radiation therapy to have on the female reproductive organs, in this case the ovary and the uterus, which would actually be very, very important at the end of the treatment when you're actually ready to get a patient pregnant. And in cases where the treatment itself has affected the patient so much, we might begin to think third-party reproduction. So we've gotten the eggs. At the point of getting the eggs for preservation, we can either freeze it as just eggs. In male preservation too, we can just freeze the sperm as just sperm, or if the patient also has a partner that's active, we can also fertilize and freeze as embryos too. Embryos just simply means egg and sperm that has grown together to become 5-day-old babies, and that's just this is going off from analyzing what kind of treatment and the extent of toxicity we expect after treatment. And then the fifth universal pathway here would be after treatment. What are we doing? Is this patient fit enough? Because after the treatment, you might need to access them to be fit enough to carry the babies that you've been able to generate for them, or access them to be prepared to get donor sperm to fertilize the eggs if that's the tissue that we've frozen before treatment, or whatever it is. We just might, after treatment, get the patient ready for conception. And there are different modalities involved, which will now take us to the available interventions. And then for the interventions, we have four groups. We have the hormone-based, which we call the gonadotropin-releasing hormone analogs. And what that does, like I said, is hormone-based, and what it does is to downregulate the woman. And what that also does is that downregulating the woman means that the hormones that are responsible for her menstrual cycle, which tells us a lot. The regular cycle, we know that patient is ovulating. With the regular cycle, we know we expect some form of radio ultrasound findings when they come in to start their treatment. And all of these findings is what we put together to figure out is patient-specific management protocol for that patient. However, the hormone-based is not definitive in fertility preservation, because the ovaries are still where they are, and they're still going to be predisposed to those chemotherapeutic agents, chemotoxic agents, and then the patient sometimes has to go through some form of radiotherapy before and after the treatment. The ovaries are still within that focus of radiotherapy, which is a known gonatoxic event for the patient. So for the intervention, I've spoken about the hormones, which are called GnRH analogs, which just helps you regulate the hormones that regulate your menstrual cycle. And what that does is that if your menstrual cycle is not regulated, there will be no antral follicles, and antral follicles is what you actually watch out to stimulate at the onset of menses in normal fertility treatment. However, that being said, we still have what we call the primordial pool of follicles. So primordial is just the latent antral follicle. So antral follicle is what you see when a woman menstruates, and it's what you expect to grow for about 2 to 12 days before collecting your eggs for preservation or fertilization, or for instance in the normal IVF cycle. But here, we like I said, we do not know how much protection these hormones give to the ovaries before chemotherapy or radiation treatment. And moving on to the second point on the intervention is what we call ovarian transposition. So what does ovarian transposition mean? It just simply means moving the ovaries from their natural position, which is going to be left and right of the uterus, in the case where a woman has to go through pelvic radiation after chemotherapy. The idea would be to laparoscopically go in and then change the position of the ovaries in a procedure we call ovarian transposition. What that simply means is that you're going to release the connection of the ovaries to the uterus in that particular plane, and then suspend them higher into the abdomen. You can suspend them into the higher paracolic gutters. You can suspend them into the anterior psoas muscles, which is also above the uterus. And what that does is that it moves the ovaries a little bit further into the abdomen, farther from your focal point of radiation. And it's been proven to also help us, preserve the ovaries, which will preserve the fertility for after radiation, and then fertility treatment can commence once basic training is past those treatment. So I've mentioned too the gonadotropin releasing hormone analogs to shut down regulate the patient. I've also mentioned ovarian tissue transposition. And then the third option here would be what we call oophorectomy. What does that simply mean? It just simply means taking out the ovaries from the anatomical position now out into the lab. In normal IVF, the ovaries are there. We extract the eggs from the ovaries and work with the eggs after the body. In this case, in what we call oophorectomy, we laparoscopically resect the ovaries. We bring them out from the human's body in the lab. We chop them up into pieces and then we freeze them. And that being said, for the oophorectomy, I'll talk more about that when I break it down. The intervention is that we freeze the ovarian tissue like that. And do not forget that I said that we have what we call the antral follicle, and then we have the primordial follicle. Primordial follicle are the latent follicles that batches into antral follicle monthly whenever I see your menses. So let's just say that the primordial follicles are the latent follicles, and that's like the reservoir. Let me put it that way. So the primordial follicles are the reservoir of follicles, and the antral follicles are the batched for every particular cycle when you start your menses to help you get from your menses in the first 14 days of the cycle to ovulation. And then if pregnancy occurs, you don't see your menses. If pregnancy does not occur, you see your menses, and then you have another batch of antral follicle from the primordial pole present themselves for the opportunity to help you get pregnant in the next cycle. And we cannot talk about oophorectomy without talking about in vitro materialization. So in vitro materialization is, like I said, you've taken out the ovaries, and majority of what you have on the ovaries are what we call the primordial follicles. And like I said, they have to go through primary and secondary stage to become antral follicles. So by passing that stage outside the body, now inside the lab, is what we call in vitro materialization. So there are cases where you have ovarian tissue frozen in the lab, and before you can use this ovarian tissue to achieve eggs to fertilize your sperm in the lab, you have to go through the process called in vitro materialization. That's maturing the eggs from the level of the primordial follicle in the lab outside the body to antral follicles now that can now grown into those follicles that are going to give you eggs in the lab that you're now going to use to fertilize your sperm to generate babies. So let's just backtrack this a little bit. That we can start these interventions from taking out the ovaries completely, and at that point our target will be primordial follicles. And then once you have your primordial follicles in the lab, patient is ready for fertilization. You're going to start your maturation in a process we call in vitro maturization. So what that does, like I said, is to bring the primordial follicle from the primary and secondary stages to antral follicles that are matured enough to grow eggs for that particular cycle. And I mentioned you can continue to freeze the ovarian tissue. By the time you do your in vitro maturization, you now have oocytes that you can work with. You can either freeze the oocyte too. When I mean oocytes are just eggs from the ovaries. You can freeze the oocyte or go ahead to fertilize with sperm in whatever case. If the patient at that point has a partner, you can fertilize those eggs at that level before you freeze, and then you can freeze the eggs alone, and then for fertilization with sperm at a later day. And then also, if this is applicable to fertility preservation in male, where we are preserving testicular tissue which has sperm in them, not just sperm you you use to fertilize the normal IVF as normal ejaculate. So sometimes we have to go into the testicles, extract some tissue for freezing for a later date. So what happens there is what's happening in the case of oophorectomy, so that you're freezing the whole tissue, that actually contains the eggs for maturation at a later date, to the point where you can use those eggs to generate babies by fertilizing with either own sperm or donor sperm. And like I said, so at this point, you can freeze just sperm, you can freeze just eggs, you can freeze just ovarian tissue. And also, in some cases, when the patient has an active partner, you can get your eggs fertilized and then freeze as embryos, which to me I think is the best procedure for better results and better guarantees in the future. And we've been able to talk about oophorectomy, ovarian transposition, gonadotropin releasing hormone analogs, and also some of the storage for the ovarian tissue, for the sperm, and also sometimes for the fourth point, ovarian stimulation protocol. So for our patient also, from your assessment, you might be able to figure out, what is best for the patient. And the older they are, the higher the doses they have to use, which is directly related to the age-related fertility loss associated with advanced age. I've spoken about storage, and the question is, what are the subsequent outcome, subsequent options after treatment. So in some cases you might want to transplant this ovarian tissue back into the patient if the patient is fit post gonadotoxic treatment like chemotherapy or radiation. If you at that level froze just eggs from ovarian stimulation, you might have to start thinking of fertilizing those eggs. And if you had to freeze your sperm, you might, at that point, also begin to think of fertilizing the sperm with eggs to generate babies. And above all, you need to be very, very, very sure that, after treatment, your patient, in this case, female, is actually fit enough and must have gone through a series of screening tests to make sure that she's actually fit for that pregnancy without increased risk of morbidity and mortality. With all of this being said, I hope I've been able to break this down for you. And we cannot overemphasize the importance in this age where we are encouraging women to do a lot more. A lot of women are actually actively chasing their careers. We have a lot of sports women who might not have it easy making babies like this. You have a lot of same-sex couples these days, and we just have to carry everybody along. No one is left behind, and everyone actually deserves the right to parenthood. Thank you so much. Thank you for your time. And at this point, like I said, I think it's very, very important that we just train some frequently asked questions about this topic. And it is the awareness is increasing rapidly globally because of increased demands, and also I think because there's better technology in cancer diagnosis, early onset diagnosis, where we get to have a lot of room to talk about these decisions, go through the universal pathways and interventions to help this patient get from where they are to where they want to be, which is most of the times going through chemo, surviving cancer, and wanting to be intending mothers again. Without further ado, we'll go straight to the questions, and then I'll read them out for popular demand, and then I'll also take the answers. The first question here would be, how many opportunities as fertility preservation does a woman have? Well, my answer to that would be there's no cast in stone answer for that, depending on how the patient comes, depending on the age of the patient, depending on the kind of cancer diagnosis, depending on the kind of cancer treatment and regimen. this patient is going to be predisposed to. And usually, the time interval between diagnosis and onset of treatment determines how much you can actually do for this patient, because sometimes some of them have times to go through multiple cycle, and when I'm multiple cycle, which is going to be our fourth point in intervention, which is going to be ovarian stimulation protocol. Based on your assessment, you would have an idea from your blood work, antimalarial hormone, and your antral follicle count scan, how much oocytes when I'm oocyte, how much eggs you have access to in that particular time, on the right doses of medications, from your pre-treatment. And with increasing age, sincerely speaking, a lot of our patients might actually have to go through the ovarian stimulation and egg collection process for freezing multiple times. However, if the patient is younger and at your first attempt you have convinced number of eggs, yes, I think you can do it once. But once the woman is above 35 years old with clinically confirmed reduced ovarian reserve, you might have to stimulate her twice for the opportunity to get multiple and a good number of eggs before she goes into treatment. And like I said, it's not cast in stone. Different patients, different parameters, different findings, and different options. I hope I've been able to answer that question. And then, is there age limit? There is no age limit. That's the second question frequently asked. Is there any age limit for fertility preservation? And truth is, there's no age limit. And like I said, regardless of the patient's age, you still have to screen to know what is feasible. And from what is feasible, you might want to recommend multiple stimulation and collection before treatment, or if the patient is actually young enough and have still good ovarian reserve, which is also relative to good air quality. You might just have to do it once and then have the patient go through their treatment, and then just leave it at that. Third question here would be, what age is suitable for ovarian oocyte preservation? Like, what age is suitable for freezing eggs before treatment? I think that's what that question says. And from the second question, I said that the older the patient is, the lower the ovarian reserve, which is number of eggs you can access in that particular cycle, the lower the quality those eggs you're actually going to be getting. So is there an age limit? No. But you might have to do more for patients who are above 35, unlike patients that are under that, with better ovarian reserve and better egg quality. Yeah. So if we have any other questions, you know how to find us: Instagram, Twitter, Facebook, and I know we are now on TikTok, so we're everywhere. And we'll be waiting to answer your questions. Thank you very much.